This program is brought to you by Emory University.
All right, good morning and welcome to Cardiovascular Grand Rounds. We have a treat today. Dr. Spencer King will be giving the talk today. And Spencer was born in Charleston, South Carolina, and soon after that moved to Macon. His mother was a musician and his father was a history professor, I believe. Is that right, Spencer? Yep. And then he went to school at Mercer and then Medical College of Georgia. He actually served in Vietnam and started at Emory in 1966, I believe. So, I could get up here and tell you all the different things that are on his resume. What his resume sort of virtues are and all the things that he has accomplished. But I think for all of us in the room, as we sort of think about Spencer and what he has meant to Emory and to each of us, if you talk to our interventional colleagues, he's been a mentor and someone who has helped promote those who have trained under him. How he's accomplished that, he's always been very kind to people. He's very thoughtful. I can recall my father back in the 70s talking about patients that he would refer up to Emory for procedures, and how Dr. King would take that phone call and would call people back. He built quite a practice in communicating with referring physicians. As the field of coronary angiography and then later interventional cardiology came in, he and Dr. Douglas and Dr. Morris were very instrumental in getting Andreas Gruentzig to move to Atlanta in 1980, and that had a major impact, and certainly with what went on with interventional cardiology and angioplasty and the numbers of people who trained here and came here for courses, and as you look around the country at people who are directing interventional laboratories, they all knew Spencer King and know Spencer, and he remains quite active. He helped develop the interventional cardiology boards, the subspecialty of interventional cardiology, was able to interact well with our surgical colleagues and designing trials that would compare angioplasty with surgery. And he's going to be giving some of that history here today. So, Spencer, we want to thank you, and thank you for being here and for what you continue to do for Emory and for cardiology.
Okay, Andy, I expected more of a roast than that, but thank you.
I did forget one story about Spencer that I recall, and I think it's true, and that is that, back in the early days of a very new procedure, Spencer was really responsible for going around and sharing the news about how things were done. So he was traveling very frequently. I think we referred to him as the Delta Professor of Medicine at the time. And just to let you know how times have changed, one time he went and drove, had to rush to get to the airport, did the curbside check-in at the Atlanta airport, got to the gate, and then ended up having to find a telephone on the wall to call back to his secretary to say, I left my car running at the check-in, at the curbside check-in. He had left his car running there to get on the plane. That would not happen today, but Spencer, you can confirm whether that happened or not.
It did happen in Charlotte, who some of you remember, Charlotte Frederick, went to my house, broke in, got my keys, went out to the airport, got the car, and rescued it. And for those of you who did know her, she died 2 months ago, and the funeral was here. It was quite moving. Okay, you've used up most of my time, so I'll conclude by saying a few things. what I'm going to try to do is give you a very brief history. This is not mostly history. I probably should leave it out. But I'll give you a little glimpse of that. And then I want to talk about some of the unsolved problems in interventional cardiology and perhaps how we might address some of those things. The history here, I won't belabor, but you all know it, starting with Forceman and going all through until we get to what we thought was the next step, which was bioabsorbable scaffolds. But in any case, let me tell you about 4 stages of interventional cardiology. First, the balloon. Andreas developed this. He developed it for the periphery, and then in 1976, he brought a miniaturized version to Miami Beach and showed this poster. This is where I met him in 1976. We had a poster on the back side, which I believe John Hurst was the fellow that I had there, and we had this poster on. John, I forget, it was something about, everybody's forgotten what it was about by now, it doesn't matter. Andreas the next year came to the American Heart again and presented this case. This was case number 4 that he had done. Started with the patients, and he dilated this left main and got so much excitement that people started flocking to Zurich and see what was going on and began to hold these meetings. And in 1980, he came to me and said he was going to leave Zurich, and long story, but we convinced him to come to Emory. And I'll show you this just to give you a little glimpse of his personality. This is the first course at Emory. Andreas?
Yes?
Are you ready to go with your transmission?
We're ready to go.
We're ready for you. Let's go ahead.
We already have done our angiogram, Dr. Holland. The stenosis is here. This is the stenosis. And the continuation of the stenosis is the diagonal. So we have the wire ready here. We have the catheter here. It's cranial ungulated. The whole thing is taken this way and this way. So how's your chest, Lucia?
Well, you must have the balloon working now.
You must have the balloon working. Yeah. It worked, yes. What do you feel now? What kind of pain was that? Can you describe the location?
No pain. But how is it going?
Wait a minute. Behind the chest? Here are 2 interests in conflict. You may see this. The interest. The patient wants to know how it's going, and I want to know how the pain was. So there are 2 interests, conflicts here. And the patient is always right, so we answer his question. I think it's going all right. We have crossed the stenosis, inflated the balloon.
It opened it up?
It opened it up, yes. But we are not finished yet.
No, that's...
And now you answer my question. This is the glass we are using to protect us from X-ray radiation, with side glasses as well. Then we have also something here which I'll show you, is to protect our, can you see it? Protect our fluoride against radiation. The other things are routine, but a very, very intrinsic component of the whole procedure are those shoes. Without it, you will never make it. Can you show the shoes? Here, come down to the shoes. Without those shoes, I tell you something we never make. Okay, next time.
Okay, Andreas, we'll see you over here. So he was certainly a charismatic, interesting, and amazing fellow who was with us for 5 years until he died in a plane crash, as you all recall. And people began to flock to Emory for those courses, and we held 10 of them while he was here, and then continued those after. And they are the birth of the EPIC series, which continues till today. Andreas had some other observations just before he died.
That's quite a good answer. But the more we depart, as I said, to more diffuse disease, the more we have to change our directions to additional catheter systems. Catheters or instruments which then could solve problems like getting rid of a dissection, which is like a flap hanging in the lumen, obstructing the blood flow. Catheters who are able to eliminate embolizations, plaques, thrombi, etc. So We have to have more armamentarium than the balloon catheter only. We need more than that.
So his idea that we needed more than that was certainly true in the late 80s. The period I call the new device era came about. This involved all kinds of things: lasers of various sorts, atherectomy devices, rotational directional atherectomy, extraction atherectomy, all kinds of things, and very importantly, stents. And stents became the thing that lasted. And of course, the stents created more problems, as you all know, with the restenosis, which was addressed eventually by the drug-eluting stents. Maybe some interim things there. If we had longer time, we'd talk about radiation. But drug-eluting stents came into being, and subsequently so many improvements in the technology of stents, which became the hallmark of interventional cardiology. But they still have problems, and we're now learning more and more about in-stent neoatherosclerosis, which is not a rare event, and we're learning a great deal about that. On the bottom right, you see that bare metal stents have this as well as drug-eluting stents, but drug-eluting stents seem to develop this earlier. Part of the problem with the stents that we have has to do with shear forces, which Habib and the group have been working on so much. This has been particularly problematic with the bioabsorbable scaffolds, which are high profile, create a lot of flow disruption. That's been studied extensively here. And some of what the outcome of that flow disruption, one of the things is that the endothelial healing is abnormal. This is also probably influenced by the drug, but this is Alok Finn's work. The abnormal shear force on the right here creates a cobblestone kind of appearance, and the gap junctions between endothelial cells is permeable and may be one of the etiologies of in-stent neoatherosclerosis. So eventually we came to this idea of bioabsorbable scaffolds, and that's where we kind of were. So I want to now talk to you about the things I really came to talk about, which are some of the unsolved questions. And here are 5 of them. There are many, many more, but let's talk very quickly about these 5. One is, does PCI improve survival in stable disease? Okay. Left main, where are we going with that? STEMI, what's happening? How do we approach STEMI? We treat them all with PCI, but how do we do it? Chronic total occlusion, is it worth doing or not? And bioabsorbable scaffolds, what's happened to that? So we'll skip through most of the old data because of time and try to just talk about some of the new things that we have to deal with. Here's the Courage trial everybody knows about, which resulted in no change in survival, whether you're treated medically or surgically for stable ischemic disease, and highly criticized over the years, and was done with equipment that we don't use much anymore. But anyway, that's what's been there, stuck in the guidelines forever. Then we came upon the idea, well, maybe we should be doing just lesions that are important, that have flow-limiting things, and so we learned that from the FAME trial, and then FAME 2 set out to understand if we use this guide of not just anatomy but physiology to figure out how to treat the patient, we might do better. So in FAME 2, as you recall, patients all had FFR measured, and if they had abnormal FFR, they were randomized to PCI or to stick with medical therapy alone. And when that was done, the patients in red were the ones who had obstructive lesion, but it was not treated. And there you see a much higher event rate. But the events here are driven almost entirely by repeat revascularization. If you treated the patient, the outcome was similar to patients who didn't have obstruction by FFR. Now that trial has been followed and out to 3 years, and this was reported at the TCT meeting in Denver, looking at not only the outcome at 3 years, but also the economic impact of treating or not treating the significant lesions. So these are all the patients who had FFR less than 0.8, roughly 450 in each group. And you see that the MACE event rate looks the same. There's not much happening between year 1 and year 3 in this study, but the economic impact changed over time. Turns out that about half the patients who had no stent placed end up with stents anyway, and over time the cost equilibrated between the ones who were randomized to go ahead and stent them and the ones who were not stented. So that was new news from the from TCT that might influence us a little bit. 3-year results show that PCI improves outcomes and is economically attractive if you consider equivalence economically attractive. FAME-3 is an ongoing trial that's going to use physiology, again, to randomize patients between surgery and PCI. A 1,500 patient trial that is not yet completed, but we'll be hearing about it. So here's the one that got all the news at TCT. This is the ORBITA trial, which is the first sham control randomized trial in interventional cardiology. Everybody's talked about this in the past. What's the if you get better, is it because you think you're better or not? So this is looking at placebo effect and the physical effect. So what happened here was this is in the UK. They took patients who had angina. They treated them intensively for 6 weeks with getting up to 2 anti-anginal medications. They then did a battery of tests. It's going to probably be hard to read there, but they did stress tests. They categorized them by Canadian class, by questionnaire, anginal questionnaire. They did dobutamine stress echoes on all these people, and they had a cath. So they knew the anatomy. They knew a good deal of the physiology. Then they brought them in and randomized them. And at the time of the procedure, they had a headset on. They listened to music and things. They sedated them. And they did FFR and IFR in all these patients. The procedure was not driven by that, and the operators were not told what the FFR or IFR values were. So they went ahead, they stented the ones that were randomized to stent. They didn't stent the others. These are all single vessel disease. And then they were followed up by a group that were not involved in the cath. The people involved in the cath were excluded in the follow-up. At the bottom left, you see some people say, well, yeah, but what kind of patients were these? Obviously, must not have been very bad. I've blown up the first 12 patients. They published in the paper the angiogram, angiographic images of the first 12, and here they are. And you see a proximal LAD up here. You see a mid LAD here, another proximal LAD, not as bad. There's a circ lesion, a mid circ. Here's a really super tight right down here, another LAD. Turns out that 60% of these were LAD, more or less in the proximal portion, and they all had ischemia. Well, when they did this, the endpoint was going to be angina relief. Obviously, they're not looking at single vessel disease survival. They're looking at relief of angina. And the objective measure was to be time on treadmill. And they projected that they would increase at least 30 seconds on the treadmill if they had stenting as opposed to not being stented. And it turned out, as you can see here, the placebo group increased by 11.8 seconds, the PCI by 28. So the difference was not 30 seconds, it was only 16 seconds between these. Then they also had the questionnaires. They had the they had no change there. The Canadian class didn't change. The only thing that was different between these two groups was the dobutamine stress echo, which showed a bit of improvement in the ones who had stenting. So this was a kind of a shocker, I think, to a lot of us. There are some limitations to this study. Obviously, this is not multivessel. They make the point this is single vessel disease, but it's clear-cut angina. It is does not mimic practice, in my view, because all the patients were intensively treated with anti-anginals, including the follow-up. So when you stent somebody and they have the single vessel disease and the stent's open and you think you've gotten rid of all the ischemia, do you continue them on calcium blockers and beta blockers going forward? In this case they did, because they wanted everybody to be treated the same, but you wonder if the exercise time might have been inhibited a little bit by the beta blocker. I don't know, but it's a possibility. And the point that both groups' angina was improved is true, but it doesn't necessarily say that, okay, this means that you cannot, that you should only use medication for the rest of your life and not have a stent, nor does it say you should stent. But the fact that this could be done and that it brought out this importance of the placebo effect is very sobering to all of us. And in terms of future trials, I think it's going to be something we have to think about. All right, what about, so how do we go forward from this in stable disease? I don't think all the general trials, including everybody, it gives you an average, and it may not tell us enough. I think trials large enough to drill down to all kind of subsets will be important. There's going to be a need for trials of low ischemic risk, like this. And you can say that these patients aren't going to change practice, but I can tell you these patients are treated a lot all the time. These aren't the majority of patients. The majority of patients actually are acute syndromes, which these weren't. The ischemia trial, which comes at it at an earlier stage, that is, they're randomized based on the nuclear stress test. This is going to pick up patients who have a lot of ischemia. That will be very interesting in the future. But I think the anatomy is also going to be interesting. And I can tell you in the ischemia trial, there are blinded CT angiograms done on everybody. So in retrospect, they can go back and see if the anatomy was also helpful. And should they be more sham controlled? People say, oh, well, this could never happen in the U.S. We're too in favor of individual rights to not know anything. But in the UK, they said, well, maybe the group would like to know something, so they do it. I've come down the side of this not being evil to do a sham control. I wrote an editorial about this after the HEAT trial, which was another UK trial of sham control. So I think something to be learned from these things. All right, let's change gears. What about left main? Left main, we're in a bit of a debate about whether left main is okay or not okay. It occurs in 5 to 7% of patients who undergo cath, and if you don't treat it, historically, you had about a 50% 3-year mortality. Probably not true now, but nobody's untreated now, so how would we ever know? Remember, Andreas did this first patient with a left main, and it was the fourth patient he did was a left main. But then he published after that something, we won't read the whole thing, but basically this says that the patient died, and by the way, don't do this anymore. And largely that's what we did. We quit, nobody did unprotected left mains for many years, and it was a class 3 in the guidelines forever. Now we have improved technology. We've learned a few things from observational studies, and starting with Syntex through these last two, XL and Noble, we do know more things about left main. There has been a contrast between these two trials using modern stents, XL and Noble. XL is a 3-year outcome study of patients with low to intermediate scores, and Noble had a 5-year endpoint, although not everybody has followed 5 years, with low Syntex score. XL showed equivalence in that study at that endpoint between surgery and PCI. Noble showed that surgery was better. So everybody says, well, which one of these is correct? Let's look at them just quickly. There are some differences. XL, low to intermediate scores. Primary endpoint here was death, stroke, or MI, hard endpoints at 3 years. And they were the same, as you can see, 15 and 14. Secondary endpoints, early endpoints, 30 days, that was a predetermined, was better for PCI. If you talk about death, stroke, or MI, it's driven by periprocedural MI and stroke. For the secondary endpoint, which included revascularization at 3 years, PCI was non-inferior. The surgery with surgery having actually 19% of those events, PCI 23. The Noble trial was a 3-year trial, a bit shorter, and here the composite endpoint included revascularization, urgent revascularization. So those are some differences in the trial, and when you put them up beside each other, on the left you see XL, which looks equivalent, and on the right you see Noble, which looks like surgery is better. But if you include revascularization in both of these trials, you see the difference does not look as significant. So we need longer-term follow-up on the XL trial to really know whether these things are going to be that different. There's a meta-analysis of all 4 of these trials that reflects more or less equivalence. So this has led us in left main disease to the conclusion, which we largely knew from Syntex, that patients with left main disease without a lot of other disease, that is a low to intermediate Syntex score, could be treated reasonably well with PCI, and you didn't have to have surgery. So left main PCI is reasonably safe. Outcomes in the trial show non-inferiority to surgery for the hard endpoints. And we need longer-term follow-up. So how does that reflect in the guidelines? The guidelines now say left main is okay to do. The only difference between the European and U.S. guidelines are that in intermediate Syntex score patients, the European guidelines give it a 2A, and the ACC/AHA gives it a 2B. And a lot is made over this, but remember, the words that go with 2A are should be considered. Left main, in these cases, should be considered. 2B is might be considered. So these are not dramatic differences in what the intent is for the guideline. For high Syntex score, still in both guidelines, it's a contraindication, class 3 indication for PCI. And all those patients should go to surgery according to guidelines. Remember that all kind of lesions in left main, you can't lump them all together. There's osteal lesions, the shaft lesions, the distal bifurcation lesions, and those bifurcation lesions represent 80% of the left main work, and so they're very important. This is the paper presented at TCT and published in JACC just now from international group, including Dr. Rabb, who, by the way, commented about this trial at the end of it. But what it surprisingly showed was that our it's kind of the common wisdom is, if you got left main, use one stent if at all possible. And this trial started out dealing with bifurcation disease, so they randomized him between one stent and doing a DK crush two-stent technique. And the two-stent technique came out better in this trial, as you can see, as far as target lesion failure and stent thrombosis. So both of them tended to be better. The results of the DK crush were remarkable, with a stent thrombosis rate of left main bifurcation of less than 0.5%. I invite you to talk to Dr. Rabb about this, because he was the commentator, and this is his article about that. So what about left main? What else do we need to know? We need longer-term follow-up. We know a lot about the internal mammary artery, and it lasts forever, and we don't know that kind of follow-up with interventional therapy for left main. We're excited about it. It looks pretty good. Maybe to 5 years. And maybe it's going to be the thing to do. So we should continue to be excited about that. Let me say that I may be missing a slide, but in the guidelines, let me go back to the guidelines just for a second here, because when we think about left main and we think about the recommendation of the guidelines, remember that most of the patients don't fall into the guidelines. So here's a small item down here that the exceptions to not doing high-risk left main patients, the exceptions to doing surgery in all those are patients in whom surgery is, they're not eligible for surgery, got high surgical risk, end-stage lung, renal, hepatic disease, complex disease that's not suitable for surgery, emergency PCI, that sort of thing. Shock patients coming in, acute MI. So there are a host of things with left main that are done that don't have anything to do with this guideline. So another question number 3, is going to be, what do we do about STEMI? So there's no contest about what we should do about STEMI. They should go to cath lab and get opened up as quickly as possible. So that's no longer a question about thrombolysis and the rest of it. Question is, what do you do when you get them in the cath lab? Do you open everything? Do you open just the infarct artery? Do you open the infarct artery and come back the next day or next week and do some more work? So this has been extensively studied, and one of the meta-analyses that was in JACC Intervention is here, looking at all those 3 strategies of treating these patients. These network meta-analyses, putting all kinds of trials together, trying to sort out what tends to be the best outcome. In that trial, if you look at the infarct only versus multivessel at the same time, see at the top, most of the observational retrospective studies have tended to say, don't do multivessel at the same time. Do the infarct artery and get out of there. And that's what drove guidelines for a long time. Some prospective studies say, well, it's pretty much a wash. The strategy of infarct artery only versus staged multivessel is a little different. And here, the staged may be a little bit better if you add up all the numbers, again, the average. And when you compare doing a single procedure, multivessel, do everything at once, versus stage them, it turns out that most of the evidence is in the favor of staging rather than doing multivessel at one time. So in patients with multivessel disease presenting with STEMI, stage multivessel may be better. There are a bunch of other observations. This is one from Canada that suggesting we'll skip it for the sake of time. Fractional flow reserve physiology has been used in this setting too to guide what we should do at the time of intervention. This particular trial randomized patients with multivessel disease using FFR to guide whether to do other arteries. And in that trial, they came down to the conclusion that the more complete revascularization was better if you limited yourself to just flow-limiting lesions identified by FFR. I'm going to skip this so I can spend a little more time on this last item here. So again at TCT, another thing that's going to change our way of thinking. In STEMI, what if the patient comes with shock? Now remember, the guidelines say, in general, stent the infarct artery, use your judgment about many things as to whether to do any other vessels, but by and large, stent that infarct artery, and that may be your best approach. But if the patient has shock, the guidelines say, no, you can do everything. You're trying to improve circulation, bail this patient out from shock, so do everything. But that was not studied. Now it has been studied. So this is this study from Germany got a huge amount of attention at TCT. This is a strategy of either taking the shock patient, STEMI patient with shock, dilating the infarct artery only, or doing multivessel intervention. The end point of this trial was death or renal failure within 30 days that resulted in renal replacement therapy. So these people either died or they're on dialysis. How did it come out? 706 patients, and you see here that that primary endpoint, death or renal replacement therapy, favored significantly culprit only. So this kind of flew in the face of what we might have thought before. Another thing is, notice in the middle here, that some of the patients, this staged PCI of non-culprit lesions means that they were randomized to the group to get only the infarct artery, but 60 of the 344 did eventually get another vessel dilated in those 30 days. So about 20% got more complete revascularization, but they got it not at the time of the acute procedure. And if you break it out by death only, you see it's still significant. Mortality was better in the culprit only. The renal replacement was trending in the same direction. So among patients who had multivessel disease and infarct with cardiogenic shock, the 30-day risk of composite of death or severe renal failure was lower among those who initially underwent PCI of the culprit only than those who underwent immediate multivessel PCI. So that's going to change guidelines, I think. So is culprit vessel inferior to multivessel? Future trials should be stratified by the clinical presentation. You can't throw these shock patients in with all kinds of other patients. We need to stratify them by the clinical presentation and the distribution of the disease burden. What is it you're going to do next? The HEAT trial from UK that kind of looked, not HEAT, PRAMI trial that did culprit only versus multivessel, was a lot of those patients, what you were leaving behind was the LAD. You did a right or you did a circ, marginal or something, and you left behind a severe LAD. We need trials that sort this out. What should we be doing in specific circumstances rather than the whole average there? I think current trials are still inconclusive, and we really need to know right now, I think, since the treating the infarct artery that you all do is what you're doing to save the myocardium and stop the infarct. And what we need to know now is what patients should you do something else to make it safer. Right now, I think it's not clear what you need to do in addition. Okay, CTOs, is it worth doing? The DECISION-CTO was a randomized trial that's been criticized because it was stopped early, but didn't show a difference in terms of opening the CTO or not opening the CTO. So that was background information that's out there that people can throw stones at. In Europe, the CTO study concluded that MACE at 12 months was similar between PCI and the optimal therapy arm, but angina was clearly improved in this trial by opening CTO on average. So one more trial from TCT addressing CTO. This trial says, well, if you open a CTO, surely you improve LV function. So this is a recovery of LV function in patients who have a CTO open. Now these are all patients who are having something else done, a non-CTO lesion, and then they've got a CTO, and the CTO is randomized to either open or not open. And the endpoint is MR-based wall motion, segmental thickening. So they did that, and the objective, as I said, is whether PCI of the CTO improves left ventricular function in addition to PCI of the relevant coexisting non-CTO lesion. Outcome, no improvement. That could be significant here. So this was, again, an interesting study. I don't know if this is going to change things dramatically, but did not give added impetus to that. If you look at MACE, and this is true of almost any CTO trial, and you throw in revascularization, then opening the CTO will always win, because the revascularization, if you didn't open the CTO at the time you did it, a lot of those are going to get the CTO opened later because of continuing angina or something. So that drives this difference favoring opening the CTO, which might have been the right answer, certainly if we're aiming for angina relief. But you see here that the MACE is driven completely by this dramatic difference, 15 versus 5% of clinically driven repeat revascularization. So you got CTO, you got angina, you treat them now, or you treat them eventually if you didn't treat them now, and you try to help with the angina. Here's another registry, which is comparing CTOs that you were successful in opening in the blue to CTOs that you either didn't try to open or failed to open. And those are always going to have higher event rates, again, driven by revascularization, but not an effect on survival. So with CTO, where do we go with this? We need more randomized trials, and sham, remember that word, may be very appropriate for this. Observational studies are not going to help us very much to understand about CTOs in terms of survival. And they're not going to help us a lot on angina relief if we believe what we saw from ORBITA. So CTO is a great opportunity to design sham-controlled trials. And with CTO, I think they need to be stratified. I think we need to know, if we're opening a CTO, you throw them all together, you get an average. But what if you leave behind LAD, CTO feeding what looks like viable chunk of myocardium? Is that different than opening a PDA that's looks dead. So I think we need to do that. So I'll close up with this this question: bioabsorbable scaffolds. What did we do with those, and where are we? Because it's a short, sad story at this moment. What we're gunning for here was a golden tube, they like to call it. That is a healed artery with the stent all gone away, and functionally good artery. The most recent randomized trial was the AIDA trial that set out to compare the best metal stents that we have now to the bioabsorbable scaffold, and as you know, this did not show a difference in target vessel failure. Didn't show any favorable thing for the scaffold. The more disturbing fact was that trial, along with others, showed increase in stent thrombosis with the scaffold. The trials that the other trials, Absorb 3 trial also had this same problem. And Absorb 3 at 1 year, you recall, actually showed a reasonable, strong trend in favor of the Xiant stent over the scaffold in terms of target lesion failure and stent thrombosis. One thing that was found in that trial was that the negative results were largely driven by smaller arteries. So arteries that were less than 2.25 millimeters by QCA had the worst outcome. So here's a reflection of the ones larger than 2.25, and that was seemingly okay. Here on the left for stent thrombosis, we didn't see any difference for the larger arteries. On the right, you see a big difference for the smaller arteries. So a recommendation came to do some new things. One is to prepare the artery better, to size the stent just right and get a better outcome. Anyway, the Absorb 3 has now been followed out for 3 years, and as you can see on the left, the difference is now approaching significance in terms of target lesion failure, favoring the Xiant stent. On the right is a landmark analysis showing that things aren't getting better between 1 year and 3 years. The promise of drug-eluting absorbable stents, of course, is longer than that. You know, the promise is, well, let's follow them to 10 years, and maybe between 3 and 10, that's going to be better. But that's all for future contemplation. The device thrombosis has been the thing that's really been the nail in the coffin, because in Absorb 3 as well, device thrombosis at 3 years turned out to be worse, is still worse. And even after the 2-year follow-up, after the 1-year follow-up, it continues to be a problem for the drug-eluting stent. So in Absorb 3, 3-year adverse event rates were higher with BVS and EES, particularly MI and so forth. The method of getting a better, doing all these things, the so-called PSP, prepare the artery, size it right, and post-dilate it, are things that require high-pressure balloons and so forth. And to assure you that you've got that, you've got all these methods. You can do OCT, you can do IVUS, you can do QCA to try to figure it out. All of these things are going to require a lot of effort, which may be good and necessary. So they started a new trial called Absorb 4. And Absorb 4, this just shows you trying to get the optimal outcome using OCT, which we believe is probably the optimal thing to do that with. I'll tell you about Absorb 4 in a second. We ended up writing the editorial that's in this week's Jack about this, and we said, can the vanishing stent reappear? we agree with Abbott. They've stopped selling these things, that's a good idea. And we also feel that, before any randomized trials happen now, there ought to be a better mousetrap. They need to iterate these stents, not only Abbott, but anybody else doing it, to try to overcome the problems that exist. The Absorb 4 uses all these techniques to try to get a better outcome, and that trial is still ongoing, but they reported the 30-day outcome at the meeting, and even with that, you see that the Absorb stent is not beating the Xiant stent, even for 30-day outcomes. So where do we go in the future? I think technical improvements need to happen before any further randomized trials. So let me conclude by saying that despite 40 years of interventions, there are many remaining questions. These are just 5 of them, and I'll stop here and let you ask some questions, but tell you that we had this textbook a few years ago about interventional cardiology, and now there's a new one. The first thing I'm going to say is don't judge a book by its cover. I declare we all would like to be excused from this garish cover, but this is being released at the American Heart meeting, and fortunately for everyone, it'll be an online version which will not have the cover like this. So that will be good. But this is a very comprehensive book on interventional cardiology that Habib took the lead on this time around, and I think it's a great piece of work. So that's all I've got. Thank you very much.
So great. Thank you very much, Spencer. That was a real tour de force and sort of an overall view of the field from the beginning to the present. So let's open it up to questions. Andy?
Spencer, just a comment. As I was listening to the information on the Absorb stent, I thought back to Dr. Logue, who I know had a dramatic impact on your career. But Dr. Logue used to say, use the new drugs while they still work. And I guess we can say that about the new technology as well. So.
Yeah, Dr. Logue had a little bit of Johnny Cochran in him, too. There was a technique called the chymogram. You remember that? It's like you put you on something and you slosh around, and it was supposed to predict how your heart was doing. And one I remember Dr. Logue saying, the chymogram ain't worth a damn. So he was ahead of Johnny Cochran.
Very good, Spencer. One thing that hasn't changed over many decades is the placebo effect. And you can go back to the Weinberg operation for the young ones. That's just sticking the internal mammary artery in the left ventricular myocardium. And angina relief was way in the 70%. And someone eventually did a sham procedure, and with the angina relief being the same, without.
And they even had the one of ligating the internal mammary artery.
That's right, and scarifying the left. Yeah, there were all sorts of curious things. That was Beck, I think, that did that.
Spencer, any comments about the drug-coated balloons, especially the specialty balloons that are being done in Europe, like chocolate?
Yeah, the chocolate balloon, I think I'll change the name of that because you remember that movie, Chocolat? That was produced by the infamous sex offender. But anyway, I think drug-eluting balloon, drug-coated balloon is a real thing. I mean, I think it's been helpful in stent things. It's been helpful in the periphery, right? You guys have. We worked on this a long time ago with a porous balloon back in the 80s. We had a balloon that we drilled holes in, and experimentally we tried this in the pigs and gave up on it. Unfortunately, we gave up on it because the only drug we tested was heparin, which just created more inflammation and it was worse. So it's just one of those inventions that was not invented yet till somebody else got a better outcome. Steve?
So that little picture you showed of you and Andreas up front there was a seminal picture. Is that when you expressed his interest in, did he want to come to Atlanta or did he want to come to the USA?
He wanted to get the heck out of Zurich. He was having problems with his bosses and so forth, and so he was, and the reason he was having trouble is, you know, he was a young guy, had this new technique, he was getting a huge amount of attention. It probably could happen elsewhere. But anyway, he said that he wanted to go to Germany or US, and I said, well, I knew he didn't have a job offer in Germany because he wanted to be professor. And I said, where you want to go in the US? And he said, I think Cleveland Clinic, because that's the famous place for surgery. In fact, this past Friday, they celebrated the 50th anniversary of bypass surgery by Favalero. So I said, what do you want to do? He said, well, I want to guide the procedure. I want to be involved in everything, and I want to be a professor. And I said, well, you can't at Cleveland be a professor because they don't have a medical school, which they didn't. So then he said, well, what should I do? And I said, well, I don't know. Among other things, why don't you come visit Emory, and why don't you come see us? The next week, he went to Snowmass, to Jack Vogel's course in Snowmass, and from there he called up and said he could change his flight and he could come through Atlanta and then go spend a few days and then go back to Zurich. And so we invited him. He came and stayed, and we're in the Hearst conference room. So I can tell you candidly that when I told Dr. Hearst about this, he said, oh, don't get involved with that guy. He's a prima donna. Now, some of you don't know the background of that, but his chief of cardiology was a guy named Hans-Peter Kreinbuhl, who had been at Grady previously. And so Willis knew this guy. And in the issue of the Hearst the Heart, the year before, Willis Hearst asked Kreinbuhl to write a chapter on angioplasty. He'd heard about it. And Kreinbuhl, if you can find that edition, there's a chapter on angioplasty authored by Hans-Peter Kreinbuhl, who never did one, with no Andreas Gruentzig showing up on it. So after he said that, I said, well, look, he's staying at my house. I'd love you to meet him, at least. So it was about 10 minutes with Willis before he became an absolute enthusiast to recruit Andreas. So that's how it started.
So it took the state legislature, all of your efforts, and probably the president of the university and Charlie Hatcher to make all those arrangements and make all those things happen, including not having to take the board exams, right?
Right. He didn't want to take any exam. He wasn't eligible to take any board exam. He didn't have cardiology training or radiology training. He was an angiologist. So he was self-invented all these things. And for any immigrants in this room, it doesn't work this way anymore. But all the rules were kind of out the window. And the state license was particularly difficult, and Willis got that done. And years later, the head of the state examining board was in the cath lab down there in I think in room 3. And I was cathing this guy, and he had some versed and so I thought he was pretty asleep. And so I started telling this story about how helpful he had been in getting Andreas, his state license. And this guy awoke from stage something other anesthesia, raised it, said, never say that, never say that. He was still nervous that somebody was going to nail him for bending the rules, but the rules were clearly bent. So the thing that's out there that's absolutely untrue is it's been promulgated that the Coca-Cola company gave a bunch of money to, and Mr. Woodruff gave whatever. This was all made up stuff.
Steve,
John Douglas gave him a lot of money. That's the
John?
Well, Spencer, what we tend to forget is how important the excellent surgery was here and just keeping things afloat. I mean, to have Joe Craver and Ellis Jones, operating every day, competitive spirits that were trying to outdo each other, having them, salvage these guys we're taking with CPR down to the operating room was I think, just huge, and we just have to remember that. And those guys were just such splendid surgeons. I think they kept us afloat.
They absolutely did, and sometimes late on Friday afternoon, they did it without a great deal of humor, but they did it.
Spencer, let me just chime in for a second. So to sort of summarize what you've taught us today, right, is number one, as a leadership principle, you really listened to Andreas at the time to see what drove him, and sort of found the win-win to bring him here. And I have to say that if you think about Spencer's legacy in the last 12 years since I've been here, he's sort of done the same thing with the interventional faculty that are here, is understand what drives people and tries to support them. But I think to summarize what you said to us, or what you taught us about where interventionalists come from, for stable ischemic heart disease, basically you treat symptoms largely at the present time. For acute coronary syndromes, it's a completely different story. So my question to you is, what is the effect of medical therapy over the last 40 years, and the effect of the microvasculature, and what you told us a lot was about the epicardium. So what's your view of sort of the holistic approach to coronary disease and the changes in medical therapy and how it's impacted these various trials?
So that question coming from a physiologist is interesting. You maybe that thing we see on the angiogram is not really the reason they have an angina. That's another possibility. Maybe these all kind of things that go into it. I think that the future for medical therapy is incredible, and I think that we just begin to see the impact of what we never dreamed before, that if you could take your LDL and just totally drive it to the deck, that you could, maybe solve these things. Larry, maybe we won't have to do so much of this in the future if we can stabilize everybody. But the combination of the psychology of thinking that PCSK9 or just massive statins or whatever is going to stabilize us, then if we believe that, the former concept that I hear from all lay people I talk to, I had a stent put in. What happened? Well, I had this, and they told me I had this widowmaker, and boom, I got it. Saved my life. And I was at a Mercer board meeting. 3 people, I saved their life. I didn't save their life, but they think so. And that's the concept, that if the angiogram shows it, you're dead and you got to fix it. And I think that's where we are now, is to think more critically about that, and not take the editorial that Rita Redberg wrote about this, which is terrible. Said, this is a nail in the coffin. Angioplasty should go away. It's just worthless. That's clearly not true. But many more things to think about. So the future, I think, is exciting, because now instead of just oculostenotic reflex, we might have to even think about it.
Well, great. I mean, I think we know that people with established disease have worse prognosis, so it's just a matter of trying to figure out all the vascular biology and the predictive models to identify them. Well, with that, any other questions? Let's go ahead and close, and thank you so much for an enlightening talk.
The preceding program is copyrighted by Emory University.